Thank you, previous speakers, for giving very useful insight about the management of gestational diabetes. Firdos Madam has already told in depth about the importance of MNT in the management of GDM. So basically, many patients with gestational diabetes can be managed with MNT alone. Around 60 to 70% patient can be managed very well with the MNT, and rest of the patient need insulin. So there are some limitations for MNT in GDM in some patients, and they require insulin therapy. So why MNT fails in some patients? So sometimes patient with GDM with twins, they have higher insulin resistance, and already Swati madam has told about the as the pregnancy advances, insulin resistance increases. So there are two types of GDM. We know that early GDM and classical GDM. So in early GDM, means that is diagnosed in first trimester, you have very less insulin resistance. So that patient can be managed with less dose of insulin or MNT. But if patient, as the pregnancy advances and it becomes a case of classical GDM and it is diagnosed, that time patient develops insulin resistance because of hormonal changes, and this patient need insulin therapies. So we'll come to know, we'll see now which type of insulins to be used and what is the action profile of this insulin. So basically, if you see, these are the insulin analogs like aspart, lispro, regular insulin, that is human insulin, and insulin detimer. And one more insulin is that NPH. So the onset of insulin analog, we know that it is faster, peak is early, and duration of action is also less as compared to regular insulin. And NPH has got 6 to 8 hours action profile and duration of action. But if you see the insulin detimer, it is a peakless insulin that we know. These are the approved insulins in the management of GDM. So best is take the aspart or lispro and insulin detimer. So why this is so? Because aspart and detimer has got 18 and 84% decrease in IGF-1 receptor affinity respectively as compared to human insulin, and lispro and glargine, they have got elevated affinity for the insulin like growth factor 1 receptor. So this is the reason that aspart and detimer, they are the preferred insulin in the management of GDM. So coming to the targets of glucose values in GDM. So basically madam has already discussed this. So fasting should be kept below 95, but it should not go below 86 because we have to keep in that range, because it is shown that if you push too much sugar low in GDM, there is no added advantage, and over and above it has become, it gives more adverse outcomes like because of hypoglycemia. Then 1 hour postprandial should be kept less than 140 and 2 hour postprandial should be kept below 120. So basically below 95 and below 120, these are the best target values in pregnancy. And HbA1c should be kept in between 6 to 7. So 6 is the best if it is achieved without hypoglycemia. And in some cases where hypoglycemia is the problem, then 7 is also acceptable. So insulin is the first line of management in GDM because we know that metformin crosses the placenta, glyburide crosses the placenta. Metformin cannot be used when patient is having preeclampsia, eclampsia, hypertension, or IUGR is there. In such cases of placental insufficiency, we should not use metformin because it may cause acidosis and growth retardation of the fetus. So it is recommended that OHS should be reserved for women who are unable or unwilling to receive the insulin. So insulin should be the first choice of management in GDM. So total daily dose is 50% bolus basal insulin and 50% pre-meal or rapid-acting insulin boluses. And another thing is that 14 to 35 weeks pregnancy insulin requirement tend to increase gradually. So we have to monitor the patient very closely. At least 4 times a day, patient should do the SMBG and watch for the blood glucose level fluctuations. After 35 weeks of insulin requirement may decrease or even it becomes stable. Patient with obesity may require higher doses of insulin than non-obese patients. So we can start with a simple regimen like pre-mix insulin, that is Mixtard or 30/70, or we can start with Novomix, that is insulin analog pre-mix insulin also. So pre-mix insulin analog is the best insulin. Then this is the subcutaneous insulin, 30 minutes before breakfast once a day, and dose is calculated when as follows. Monitor 2-hour postprandial sugar and fasting sugar, and blood glucose level, if it is between 120 to 160, give 4 units. If it is between 160 to 200, give 6 units, and if more than 200, then you can give 8 units. And target values we have already discussed. Then this is the dosing guidelines, that how much dose in which weeks of gestation to be given. It is roughly around 0.7 initially, and it may go up to 1 unit, or in some cases of obesity or twin pregnancies, it may go up to 2 units per kg also. So here is the importance of some diet and exercise. If diet is not regular in GDM patient, or patient is taking fluctuating diet of carbohydrate content, then sugar may go up and down. So because of this, carbohydrate content of the GDM patient should be constant. So this is very important advice. Another thing is that exercise is very important, especially upper body exercise is very important. So if patient adopt good exercise, then insulin requirement may drop by 50% in GDM patients. So this is the importance of exercise and diet along with insulin. So during last month of pregnancy, insulin requirement may decrease and hypoglycemia may occur, especially nocturnal hypoglycemia. So we know that insulin resistance is highest in the morning time and lower in the evening time. So thank you very much.